वैसे लाइट रहना चाहिए. So good morning, everybody. Today is one of the class which we are one of the challenges. This patient was in Vijayawada, and from there they drive in the ambulance to our hospital. He has underwent two-time procedures before, one for VTC, one for IC. Later on, he was having a recurrent VT episodes. And there it becomes important how to approach this type of patients which is having recurrent VT and which has become medically refractory. So this type of case we call as VT stone because the device is giving a lot of shocks and sometimes ATPs also. So if it is happening very frequently, means more than 2 episodes in 24 hours, we call it a VT stone. So regarding this case, I will call Dr. Usman. He is our associate in our EP team, and he will be presenting regarding the this VT patient who is 62-year-old male having coronary artery disease, VT and AICD implant. So Usman, floor is now for you. You have to watch print.
Admitted in the department December 2023. He was returned to the hospital. He was having a cheek complaint of chest pains in his ISOD associated with dizziness and sweating. The patient was having a known history of diabetes since 12 years and also cervical spondylosis in the L5 and L6 phase. Upon the physical examination, they were normal. When the body echo was coming, his ejection fraction was reduced to 48%, indicating mild LV systolic dysfunction and minimal diastolic dysfunction. Whereas we can see coronary artery disease in the RDM and RCA territory. Coming to the ECG, we can see the sinus tachycardia in the rectum as well as the QRS prolongation. And because of the inclusion of APA, we can say that he was having EAD. Coming to the prolonged UTC, though it is not much significant, it's just 446. Okay. Yeah. Coming to the diagnosis, he was looking up for the CAA, that is coronary artery disease, ACS, acute coronary syndrome with non-HT elevated MI. Then for mild LV dysfunction, and he was already having diabetes and HT. Then on the CAA plus revealed that he was having CAA triple disease. So for which PTL, PTC and standing on the RCX and the L6 questions.
Year which year?
2023, sir.
2023.
Yes, December 2023. Upon which he was given a discharge medications such as aspirin and aspirin anticoagulants, statins, beta blocker, and anxiolytic drugs along with ondansetron and his diabetic as well as antibiotics. The patient then again was readmitted in the month of May 2025 with chief complaint of palpitation and sweating since 1 day. And coming to his lab investigations, his deficit count was increased to 14,700 and 9.5 HbA1c because of his diabetes history, and creatinine level was also increased to 1.75. Upon echo, upon the ECG, we came to know about QRS tachycardia, white QRS tachycardia, LAD, and non-specific intraarticular probably RUD because we can see the RS pattern in the B1. Sir, I am a product.
Yeah, whatever you do.
Yeah, sorry, sir. Then he was run on cardamom and as anti-arrhythmic drug, upon which we can say that his tachycardia has been reduced. Then the patient was again admitted in the month of July in 2025, but this time he had been developing hyperthyroidism, and also he has undergone AICD implantation after the episode in the month of June. Again, you can say that he was having a video and his ejection fraction was reduced to 45%. And here is his ecosome.
Okay. Resection. Yeah. Okay, we'll go to the next slide.
This was his ECG on the readmission in July. Again, you can see here also there was a tachycardia, lady, and intraventricular block. I think he was on cardamom. Yeah, again he was on cardamom to reduce that, and this after post cardamom ECG
Yeah.
on the scan.
Thank you, Usman. So, coming back to this patient. So, there are a lot of learning in this case. Let me go one by one first. What Usman was saying. So, number one, this patient is having coronary artery disease, which usually a lot of patients will be having. But after coronary artery disease, he started having the second thing, what is called, he started showing the VT episode. When VT comes, the first knee-jerk reflex for everybody is give amidron. Amidron is the drug of choice. If you have to give two drugs, the first drug is amidron, second is sotalol. These two drugs are usually given in any patient who is having structural heart disease. If the patient is having coronary artery disease, sotalol is also given. But if the patient is having LV dysfunction, patient is having hypertrophic cardiomyopathy, other antiarrhythmics are not applicable. Means you can't give except for amidron. So structural heart disease, when the history is there, the patient is having heart failure, patient is having coronary artery disease. Rest, we are having class 1 drug like class 1C, propafenone, flecainamide. So those drugs are contraindicated. Here we are having the choices. Either you give beta blocker, that is a class 2, or you can go for the class 3 drugs, in which there are two drugs. One is sotalol and second is amidron. So this patient has been given both the choices. Both the choices means beta blocker has already been given, and on top he has been given the amidron, and the patient was starting showing the VT. So first time you can see the some VPCs are coming here. Let me make it small. So here you can get the VPCs are coming. So whenever this VPC is coming and patient is having giddiness, palpitation, we should be very clear that now the patient started showing the VT episode, which can be sustained or non-sustained depending upon the definition. So if the patient is having, usually this is the patient is having myocardial infarction previously and 3 stent has been kept, RCA and LAD, all those things. So these are very common preparation, and after that the patient has been discharged for the first episode. After that patient having the palpitation, this is on 9/5, means almost 2 years after the episode of the coronary artery disease. So when the VT start happening, the first question we have to answer whether it is a monomorphic versus polymorphic. The whole treatment will be different. If the patient is having monomorphic VT, sorry, polymorphic VT means the VT axis is also changing and it is not happening in the long QT. Means long QT VT we call it the torsades. Usually it is due to the drug related problems or metabolic problems. But QT is normal, patient is throwing VT episode, it means some stent has thrombosed or some artery is getting ischemia. Ischemia driven VT will be having polymorphic VT. So polymorphic VT, you have to take the patient, do the angiography. Most of the time, some culprit vessels will be having stenosis, or you can say clot. Immediately open, everything is normal. But if they are throwing monomorphic VT, means same morphology what this patient was having. So you can see first time he has written clearly that is a monomorphic VT and what is DCW? Huh? Huh? Cardiovascular. Acha, white QRS. So it was a white QRS tachycardia, and so this is a very good ECG of this patient. And the well thing we have to give the possibility from where it is origin. So origin of the VT has to be decided by seeing the so monomorphic VT. The first thing is structural heart disease, means patient is having LV dysfunction, hypertrophy, coronary artery. Either of the three things. Patient is throwing VT. The treatment is AICD. Clear? So when the patient is having structural heart disease, monomorphic VT, you have to put AICD, followed by drugs, means we have to give drug plus AICD, and after that the patient is developing VT, then ablation. But if the patient is having normal LV function, normal heart, structurally normal heart, and he is developing VT, monomorphic VT, the treatment is ablation first, not the AICD. So this difference is very clear. Structurally normal heart, structurally abnormal heart. If the patient is having a structurally normal heart, in that scenario, so structurally normal heart, we have to go ablation as the first choice. Structurally abnormal heart, AICD should be first treatment. Polymorphic VT, without QT prolongation, then we have to go for the angiography and revascularization. So these three pathways should be polymorphic, long QT, means with prolonged, drug, metabolic to be corrected. Polymorphic VT without QT prolongation, it usually ischemia driven, fix the artery, do the angiography, do the angioplasty. Third comes monomorphic VT with structural abnormal heart, AICD. Monomorphic VT, structurally normal heart, ablation. So these four pathways should be very clear. Okay. Now coming to this patient. So in this patient, whenever we are entering into the, now we are clear that we are not ablated already, patient is in the ICD. This patient has come to us, this ECG has been shown to us, and we told that you have to come and we are going to for the ablation. And in this, we have to see what are the clinical features. So 2-3 things what we want, we have to identify from where it is coming. So the first lead, V1 lead is the most important lead for identifying the location. Okay, right versus left. So if you are getting RBB, it is from the right. If it is LBB, it is from the left. Sorry, RBB it is from the left, and LBB is from the right. Is it clear? Means whatever the ventricle is involved, opposite will be the bundle branch block pattern will be coming. So here V1 is positive or negative? If you see, it is almost completely negative. So V1 negative means it is a LBB pattern. Now LBB pattern is happening, we are expecting which ventricle will be diseased, right or left? Huh? Right or left? In this patient, he's having coronary artery disease, we have stented 2 stents, stent where we are putting normally? It is always on LV. Whole coronary artery disease, right ventricular infarct, all those things, except for right ventricular infarct, most of the his story is for the left ventricle. It is a lateral, posterior, anterior. These are the things now with right ventricular, with or without right ventricle. So stent we are not putting with. So whenever the patient is having coronary artery disease, the disease is mostly on the left side, first and foremost. And what we are expecting in that? Right bundle branch block. In this patient, what we are getting? Left bundle branch block. So this dictum is not applicable for the patient when the patient is having structural heart disease and in that coronary artery disease. It will be always and always from the left ventricle. So in a coronary artery disease patient, if you are getting RBB versus LBB, this differentiation doesn't make much difference. It only makes some difference whether it is near to the septum, away from the septum, all those things. If it is away from the septum, you will be getting a RBB type morphology. If it is near to the septum, which is called the midline structure, the RBB pattern may not be there. And what I am expecting in this case also. Okay. So in this, you can see this is a LBB type morphology, and second is 2-3 areas is negative. So whenever it is negative, so if you are seeing the heart like this one, this is a mitral wall, this is apex, this is base. How we identify? So if it is totally negative, it is coming from the lower side. Okay, it is everything will be from where the VT will be originating, the lead will be negative in that sense. So 2-3 areas, if you can see 2-3 and area all are negative. I am expecting somewhere from here. That is clear. Now coming to the where it is exactly, it is on the septal area or lateral area. This also we have to identify. And again, we can go in the lead 1 and AVL. So by seeing this one, I am expecting it is on the inferior and it should be on the septal. Why septal? Because your 1 and AVL, it is opposite, na? L will be here, 1 will be here. So axis will go like that. Is it clear? It means the axis, left axis, whenever it is there, it is towards the septum. So this patient is having 2-3 AVF negative, means on the inferior. 1 and AVL is positive, means lead, it is on the septum. And that's why the QRS is not very wide. It is wide, but not very wide. And V1 to V6, V1, V2, V3, V4, V5, V6, all are negative. So when it is on the base towards the mitral wall versus apex, how to identify that it is an apex of the LV or base of the LV? So if everything is negative, it toward the apex. If everything is totally positive, it is at the base. So by seeing the ECG, we can expect from where the VT is originating, and that area we have to bombard with the ablation and see what will happen in this patient. So this patient has already been, so this one important question for everybody, that when patient is receiving Cardron, Amidron, what next will happen? Hypo or hyperthyroidism, 2 things will happen. In the countries where the, what you call, iodine is sufficient, means the environment is having more sufficient, they will be developing thyrotoxicosis more. And the countries or the soil in which the hypothyroidism are common, in that hypothyroidism happen. So if you are going to differentiate between 2 countries like US versus India, if you are giving Amidron, we will be having more possibility of developing the hypothyroidism. The risk of hyperthyroidism will be more in the affluent countries, but still thyroid hypothyroidism will be more common with Amidron, not the hyperthyroidism. Hyperthyroidism is less common, and when it happens in Amidron, you have to discontinue it. You have to go for the other choices. But hypothyroidism, if it is happening, you have to just replace it. Is it clear? So hypothyroidism in developing means we have to check the TSH level. TSH is going high. It has crossed 10 because 5 to 7, 8, 9, 10, it can happen even after giving visual. Amidron induced thyroid changes is happening. So TSH will go up. But if it is repeatedly crossing 10, we have to start the drug. But if it is going less than 0.5, which we label as a thyrotoxicosis or hyperthyroidism, then we have to drop the drug. Okay, so this is the 2 important thing. And in also hyperthyroidism, or you can say thyroidism, there are 2 types: type 1 and type 2. Type 1 is immune, immediately it will happen. Type 2, I think it will be over the time, means production means there is some nodules are there, thyroid nodules overproducing, and later on it will develop. So both are different. And the response for both the hyperthyroidism, mostly we have to withdraw the drug. Okay, so he has been started with thyroid, and sometimes if you are not properly monitoring the thyroid dose, the patient will develop AF as well as VT. Both can happen because of the hyperthyroidism due to the thyroid hormone when we are not properly. So drug interaction is very, very important. How the drugs are. So Amidron we are giving, sometimes we give Lenoxin, we give warfarin, we give what you call drugs which decreases the metabolism of the Amidron. So Amidron level will go up, hypothyroidism will happen. You are giving a dose not properly knowing how much, because this is a dilated heart. This type of patients will be having very sensitivity to thyroid also. So doses has to be started with very minimal dose. So they are very intelligent enough. See, they have given 12.5. They have not started with 25. They know the time 25 it may be, if some VT will again happen. So amidron and very low dose of thyroid. Okay. So here everything is fine, and here again we will see the ECG and we will anticipate 2-3 AVF is totally negative, means inferior wall MI is there, old. And on top you can see here nothing very significant, but yes, uh, nothing significant from the anterior leads. So as such, diabetes for 14 year, hypothyroidism for 1 month, which is I think amidron induced, and their threshold was a bit less. That's why they have started is cervical spondylosis, triple vessel disease, and PTCA2, LCX, and RCA. And LCX is one of the most notorious vessels because we call it a Vido vessel as a very arrhythmic of all the VTs. So here again the same QRS and inferior location is very similar. So only thing is V2 is positive. So somewhat it is coming towards the what do you call it? Septal area. So that's why it is coming positive. Otherwise, it should be negative and more toward the apex. This is important. What you call part of this echo. So echo was showing hypertrophic chambers, and there is some aneurysm in this area. Okay. So there is an aneurysm which was causing so many drugs we have given, starting from Maxohar, there is a Mexiletine, Amidron, BD, Rosuvax, Metalazone, Prolomat. So one, two, three drugs, three anti-arrhythmic drug has been given, whatever possible, and all are not able to terminate or is not able to take control of the VT. It is still happening. In this scenario, he came to us in the last month, and then we planned that we have to go for the VT ablation. So this is the baseline ECG, and what we are doing is this AICD lead, and this is the, we can say, HD grid catheter. So it is a multipolar catheter. When you are putting one catheter and seeing point by point heart electrical activity, we are going to check. So here what we do, we take a catheter in having almost 16 poles are there. So 16 point like that you are taking. So you can directly map the heart in a very short time. What we have done in this patient. So immediately we took one catheter. It is a very costly catheter, costs around 3 lakhs. And after that, we have to fully check the two things. One thing is we want to see what is the current. When heart is having healthy, the current will be, means vertical amplitude of the that area will be 15 plus millivolts. When it is going to be disease, we call it a scarring. So we define scar as less than 5 millimeter volt. So we call as a voltage mapping of the heart. So healthy heart, there is similar voltage will be all over the left ventricle or right ventricle, whatever you do. But when the patient is having infarct has happened, this scar can be identified by seeing the voltage criteria. Voltage criteria, you are getting, oh, this area is healthy, we will say healthy, healthy, healthy. Oh, sir, voltage is low. So in that low voltage area, there are some few living cells, like gufa hoti hai na, so gufa mein do char, and these will be connected with the healthy, and they are the area from where the whole VT is going up, because these are the tunnels in the scar, or we use the word channels. So these channels are the slow pathways. Slow means the current will not be the current will not be flowing very fast. So healthy, slow, healthy. So like that it will be going on, and this VT will be going. So we have to find we have to look where these tunnels are, and we are going to bombard with the RF ablation. So this is a total procedure we call as a scar modification. In this patient, we did the same thing. So you can see we are finding the tunnel as our expectation. I was saying it is on the septal side. This is the lateral side, this is the septal side. So it was on the septal side, more on the mid basal. Means we can't say base also. Means base is the part where the mitral valve is there, and apex is the part where the apex of the heart is there. So it was not at the apex, also not at the base. It was just on the septal area below this one, and that's why the V1 lead was in the VT. Here, the V2 was positive because it is on the location on the septum and more on the posterior side. That's why it is coming as positive. Okay. And after that, you can see these whatever you are seeing. This is the ablation areas. So in this, it is running no running. So this color coding will provide what is the healthy area and what is the diseased area. So whatever the red you are seeing, these all are the scar. So this is called voltage mapping of the heart, and later on this area from where the VT was originating, there we have just given the ablation, and after that VT was terminated, and this is the aneurysm from where the VT is coming. So there is a small pouch, out pouch on the septal basal part from where the VT was coming, and this was been identified, and after that there was no VT because we identified somewhere in this channel, this is called aneurysm. There are one or two channels, or we can say tunnels, which were connecting the healthy myocardium. Scar, dead tissue will never give VT, that is clear. But in the dead, there are some living cells which are well connected with the either side with the healthy myocardium. So, like I was saying, that there is always two pathway for any VT. So here again, there is a diseased part in which there are some what you call healthy cells are there, which is going through the scars and again connecting with the healthy. So these tunnels we call as the channels. We have to identify by doing the mapping, and then we are going to just put ablations in those areas, and after that VT will get controlled. So hope you people have got what is the message for the today's class. Number one, in a case of VT, so in the case of VT, three things we have to identify. What is the background? Background will give the information what drug we have to give. If the background is coronary artery disease, we are having little choices. Beta blocker, amiodarone, sotalol. These three drugs are the commonly prescribed. If these three has been and mexiletine also, the class 2, so class 1B. So class 1B, mexiletine and phenytoin, these are two drugs which comes in that class. Morisigine is also there, but is not available. So only available in India is the mexiletine, and we'd give 51, 50, 200 milligram BD to TID. It is a very good drug for controlling when you are in doubt whether the QT is prolonged, whether the potassium is low, high, all those things. One of the best drug is mexiletine. Mexiletine is Xylocard in oral preparation. If you want to remember one drug which can be given blindly in any VT, whether the QT is prolonged, normal, it is Xylocard IV, and orally the same formulation is called mexiletine. Okay. Now coming to the second drug, that is the amiodarone, and class 3, that is amiodarone and sotalol. So these two drugs you can give in all conditions of LV dysfunction. Sotalol is only and only given in the coronary artery disease with the LV dysfunction. There you can try it, but not in the hypertrophic cardiomyopathy. We are not having the studies related to that. So coronary artery disease, structural heart disease of coronary origin, you are having two choices in class 2, that is amiodarone and sotalol. But if the patient is having hypertrophic cardiomyopathy, even though it is a structural heart disease, you can't give it. So there is a choice is only and only. What is that? That is amiodarone. So amiodarone is a blanket for atrial fibrillation, atrial tachycardia, VT, VF, all these things you can give except prolonged QT. Prolonged QT, you should never give it. It will be a difficult, and the patient will develop different legal issues also come. Okay. If the patient is pregnant, very little choice we will be left. But I don't want to venture in that part. So this is part 1. After that, if the patient is developing VT, LV dysfunction, the next comes structural versus non-structural. If it is a structural heart disease, means patient is having hypertrophic cardiomyopathy, patient is having ARVD, patient is having coronary artery disease, patient is having severe LV dysfunction or LV dysfunction. These 4 conditions are there. We will label as a structural heart disease. How to label structural heart disease? Do the echo. If you are getting dilatation of the chambers, you are getting a clear-cut coronary artery disease by seeing the ECG, previous angiographic report, you can think this is structural heart disease, LV dysfunction. What is the next? What is the next after antiarrhythmic? AICD. So implantable cardiac defibrillator is the next treatment. You are not going to say that you should go to the electrophysiologist for the RF ablation. You have to take an opinion from that, but the protocol wise, the second level is AICD. VT, structural heart disease, LV dysfunction, any of these things, you have to put AICD first. After AICD, the patient is still having the VT episode. When we are doing the device interrogation, we are getting a lot of VT episodes. In that scenario, again, even the patient has received shock or not, medicine modification means the antiarrhythmic, whatever we are giving, we have to modify. Check for the thyroid levels, whether it is fluctuating, whether it is properly been handled when the amiodarone is given. If everything is fine and patient is throwing more VT, battery of the ICD will be drained. It is not advisable. Multiple episode means ongoing arrhythmia is there. In that scenario, we have to go for the ablation. We have to go and modify the substrate which is giving the VT episodes. So, number one, antiarrhythmics. Number two, that AICD, and number three is ablation. So this is a 1, 2, 3. Mostly ablation will be successful. We have to identify from where a lot of scars will be there. In the scar, there are some tunnels are there or channels are there that we have to ablate, and the patient will be free of the VT. And if the patient is having polymorphic VT, what is the first treatment? Polymorphic. This is all we are discussing about the monomorphic VT. Polymorphic. If the patient is having polymorphic VT with normal QT, it is mostly ischemia driven. Polymorphic, normal QT, ischemia driven. You have to take the patient urgently in the cath lab, do the angiography, and open the artery. Usually, some artery will be there. The angioplasty is anti-arrhythmic. So there are situations where the angioplasty, all VT will not respond to the angioplasty, which most of interventionists will be doing. VT, sir, there is a block, they will do a stent, and after that the patient is still going VT because it is a scar-driven VT. Scar-driven VT will respond only on the drugs and later on what you call ablation. It will not respond with the angioplasty. So polymorphic, normal QT, mostly ischemia-driven, you have to do the angiography, angioplasty urgently. If the patient is having polymorphic VT and QT is prolonged, what is the next treatment? No, AICD never comes in that one. What we have to do? That what we define as long QT plus polymorphic VT. What is the name of this thing? Torsades de Pointes. So in that, this is due to the metabolic problems, drug-related problems, drug interaction. So you have to settle those things. There, the treatment is totally medical management. So polymorphic VT, next reflex should be whether it is QT is normal or prolonged. If the QT is prolonged, immediately modify the drugs. Some drugs will be causing this one. Electrolyte will be causing this one. Acid basis problem will be causing, settle it then and there. Mostly it will be settling. Some VTs will be coming. In that, what drug we have not to give? What drug you have not to give in that scenario? Prolonged QT, Torsades. People are not listening. Amiodarone. Never touch that drug. VT immediately the intervention will say, amiodarone I have given. If you have given amiodarone in that scenario, the patient will be throwing more VT. Whole night you will be shocking and it will be difficult to take out the patient. Then you have to put the temporary, pace the patient, overdrive pacing you have to do to come out of this one. So never ever give amiodarone. Amiodarone, only one contraindication that you should always remember in the ICCU. Before giving amiodarone, check the QTC. If QTC is prolonged, means acute scenario. I am not saying patient is having left bundle branch block, QT will be prolonged. There is a totally different scenario. I am saying if he is coming with a prolonged electrolyte imbalance is there, potassium is low, Patient is already receiving the Lanoxin or all those things. You give amiodarone, the QT will again prolong. Already there is a hypokalemia not corrected. QT is on the head, and the patient will start throwing the VT. So very difficult to control that VT. Why we are giving AICD in a case of LV dysfunction as a first choice, not the ablation? सब लोग सिर हिला देता है. Nobody is asking this question. Patient is having structural heart disease. Drug has been given. After that, you are putting AICD, and after that, ablation. Why not ablation before AICD? बताओ. तो एक 6 लाख का प्रोसीजर, एक 2 लाख का प्रोसीजर, पहले सीधे 6 लाख का 7 लाख का प्रोसीजर क्यों करना चाहते हो? Why you want to do? किस चीज का कंटेंट? कैसे? We are putting the AICD for the treatment, or we are putting AICD for protection? Huh? For life threatening? Why we are putting AICD in a patient of VT? First question. Anti-arrhythmia? Okay. वो तो ablation भी कर सकता था. So why not ablation and then AICD?
Will also improve the LV function. Was damaged.
Never say this answer. AICD never improve the LV function. Forget it. It is CRTD. In that CRT part, not ICD part. So in that is the C. We are putting the AICD for only one purpose. Whatever is there, protection of the patient first, number one. When you are doing the ablation, you are not making the disease normal. You are not curing like the structurally normal height like PSVT. Still there is, scar is there. Today it is okay that you have, but disease is smoldering inside. It can again peep up. If it comes out and the VT happens and blood pressure drops or VT related death happens, it will be prevented. The patient is having AICD. AICD is only and only to prevent the sudden cardiac arrest in a case of VT. It is not for treatment. If a patient is throwing a lot of VT, you are not going to put AICD. In that scenario, what you have to do? Drug. Not responding, ablate. Then wait for some time and put AICD. Otherwise, it will be a shock box. We call it a shock box. We put AICD. After that, it is also giving a shock, one by one shock. So patient has become a shock box. So that is not wrong. Yes, VT has to be controlled by drugs. And after that, put AICD, send the patient. If more VT episode is there, patient is safe. At least whenever hemodynamically unstable VT or VT is happening, it will take control over it. It will shock it, normal it. It will give ATP, normal it. Multiple episodes are coming, then we have to ablate the whatever circuit which is creating the problem. Is it clear now? So AICD is sudden cardiac arrest prevention method device. It is not for improving the pumping, and it is not for the treatment of AICD. AICD treatment is drug and followed by ablation. Is it clear? Baswaraju, you are still confused, huh? So AICD का purpose एक ही है, it is like the हम कार में क्या रहता है वो that prevents the when accident happens, airbag. It is an airbag of the patient who is having VT. It will respond when patient is having accident, means patient is having VT. So it will shock it, make it normal. That is the only purpose. It is not a treatment for VT. बहुत लोगों को प्रॉब्लम होता है, सर VT आ रहा है, let us put the AICD. Put the AICD and after see the drama, it will start giving shock because it is a robot. It doesn't know anything whether you are having any problem, and one shock is a very painful. Sometimes patient want to suicide if they get 2 or 3 shocks. They say, because here it is there, you can throw it out, but it is implanted inside you can't cut it out, na? So it becomes very difficult for when the next shock will be coming. Somebody has put one bullet on your leg. Okay, just think about it. and you are not knowing the next bullet where it is coming and which will be hitting, you will be always seeing here and there. The same scenario is with the patient who is having AICD and VT shock has come for the one time. It is a very painful, very dangerous condition for patient who has gone through it, because I have managed 5 or 6 patients in which the patient was having VT storm. He want to jump from this one. I want to dive, then getting the shock unprovoked means I am sitting, all of a sudden it is giving shock because it was inappropriate shock. Patient is having atrial fibrillation, device is not able to properly been, we can say, the tailored the parameters, and it is giving shock. Atrial fibrillation, we don't want to give shock. It is for VT and VF. So that happens when implanters are not knowing how to adjust the device, how to adjust the drugs. Certainly, this type of scenario will happen. So that's why implantation is totally different. Well, anybody can implant any interventional cardiology, but managing the VT, putting the parameters in the proper so that he should not get the inappropriate shock, and at the same time he should get the appropriate shot and treat it. This is a totally a different domain. It come under the electrophysiology. Pacemaker, anybody can implant, no problem. Nothing big in that. But AICD and CRTD, it should be under the supervision of electrophysiologists for the device interrogation and their parameters. Implant you can do, but coming to the device parameters, what you call tailoring, you have to take, because it needs a cross check of the background. How the patient, how's the thing, what are the things can happen, VPCs, how much it is. So all those information will come, and accordingly we have to modify the drugs. Okay. So thank you. And your breakfast is ready.